This is going to be very interactive. We're going to welcome your questions and your interruptions, so feel free to have those as we go along. I'm going to offer just a few minutes of introduction before we start the workshops. And I want to start by introducing the program lead. So these are our leaders. I'm going to call you guys leaders. They're the group who have run the Stanford program over the last 2 years. First started in the Department of Pediatrics at Stanford last year and then expanded to several other departments this year. It's a year-long educational program for primarily house staff, residents, and fellows who want to learn more about leadership training, but to do so within the context and lens of diversity and inclusion. So how do we take folks once they arrive at an institution and help them understand this concept of diversity 3.0, which we're going to talk about today, how infrastructure and systems building is strengthened through inclusion of everyone in our community. So we have no conflicts of interest. We're not getting any royalties from this wonderful program. And we have some social media help here. So there's a hashtag you can follow. We have some handouts that can be captured with this QR code. So if everyone wants to take their photo now, you can get your handouts. And they're also available at a bit.ly site there as well. All right. Photos are being taken. And obviously, they'll be available for you later as well. So we are going to talk about some very sensitive topics today. We're talking about things that hit home and hit home in very personal ways. Imposter syndrome, microaggressions, implicit bias, things that have challenged probably every person in this room in some form or fashion in the course of their professional training. So I do want to acknowledge that and recognize that some of these sensitive topics may be triggering, and you know, we want to take a moment and just acknowledge that and acknowledge that everyone is in a safe and healthy learning space today. What's wonderful about these small groups in the pre-con is that we can really get to the heart of a topic across 4 hours. We're going to spend the whole morning together, but we want to do so in a very safe place. So we ask that everyone's respectful of each other's comments, and you know, as the course of the morning goes and we get to know each other a little bit better, hopefully you'll share your thoughts on some of these topics as well. So our objectives today are to talk about 3 topics: imposter syndrome, both identification of the challenge of imposter syndrome and a little bit of a discussion about how to overcome imposter syndrome for individuals who you're mentoring, to understand the concept of microaggressions and implicit bias and how they change our workplace and not only the place that we train our residents and teach in, but also how we take care of one another as staff in our department and how we improve our patient care. And then lastly, we're going to provide you with a toolkit. I know when I walked around the room this morning, everyone wanted some ideas to take back to their own institutions. We're going to provide that toolkit for you as the morning goes along. So I want to talk a little bit about inclusion, and I want to talk a little bit about belonging as a point of introduction this morning. I'm going to tell 2 stories about my own experiences with inclusion. I'll say that I'm a cis male, gay, married, have a child. I've had some of my own struggles along the way. I'm still a white male with privilege along the way. I recognize both of those things. But I'm going to tell 2 stories that I think are partly funny, partly instructive. The first is sort of funny. So when I was in 8th grade, between 7th and 8th grade, my parents sent me to basketball camp. So my grade school got a basketball team for the first time, and I played basketball for 7th grade. I was terrible. I spent most of the year on the bench. Our team was terrible. We won 1 game. So my parents thought this would be a really nice summer treat, right? So I lived in upstate New York. That's where I grew up, near Siena College. If anyone knows Siena, they're a bracket buster team. So I went to Siena's basketball camp, and what was interesting was that the basketball camp was set up as 5th to 7th graders and then 8th grade to seniors in high school. And you can imagine this, when he was in 8th grade, was even shorter and really quite terrible at basketball. And I was playing against kids in high school, seniors in high school, who were trying to get Division I scholarships. Right? I had no business being in that particular bracket of the basketball camp. I certainly didn't feel included. I learned nothing. It was terrible. And it was one of my first experiences of really, truly not feeling like I belonged. Sort of a silly story, but one that sits with me still, right? Why would this experience in 7th grade sit with me so long? Another more pertinent one for medicine, I was on a 4th-year sub-I. I was a 4th-year medical student. I was trying to decide between emergency medicine and anesthesia. And I did my emergency medicine rotation. I thought it was great. I went and did an anesthesia rotation at a community hospital in suburban Chicago, in a kind of well-to-do, affluent neighborhood. And mostly private practice sort of patients. And in between cases, I went to the doctor's lounge, where the anesthesiologists all sat and read the paper. And they had a really great coffee maker there. Like, with this fancy machine I'd never seen. It was like when you go to Starbucks, how they make your coffee. I'd never seen one, like where you could just push a button and someone would give you coffee. I thought this was a really big deal for me. And I'll tell you, I'm a first-gen college student. My parents, my mom was an ER nurse. My dad was a fireman. When a fireman and an ER nurse get together, they make an ER doctor, by the way. That's how that works. So I'm first gen, and I thought this coffee maker is really impressive. Like, that was enough for me. But I'm in the doctor's lounge, and all the anesthesiologists, who are all white men, probably all in their 50s and up. I think I was the youngest person in the room by about 25 years. They're all reading the newspaper. They're all reading the stock pages. And one of them said to me, hey, what stocks do you have? I'll tell you how they did today. And I said, I don't have any stocks. And they all just looked at each other, and they're like, well, what stocks do your parents have? I'll tell you how they did today. And I was like, well, I'm certain that my parents don't have any stocks. And I felt very excluded. Like, immediately felt very excluded. And they went on to ask question after question that drove home that I was first gen, that drove home that I did not belong in that room until I finally left the room. And I left anesthesia, right? I went back down to the emergency department. I felt my people. Thank God for you guys, right? I felt my people, and I felt my place that I belonged. So it's terrible, right? I mean, maybe I would have been the world's greatest anesthesiologist, who knows, right? We could have lost out. Because we created a very difficult environment for me to learn in. We don't want that for any of our trainees, right? We don't want to set up our emergency departments in any way to reflect that. So what was that day? Was that a microaggression? Probably. Like bang, 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 right? It's chipping away at you. Was that my imposter syndrome? Absolutely. A kid, a first-gen kid, who feels like he doesn't belong already, who just wants one of the anesthesiologists to say hello and welcome me to their field, right? I mean, that certainly was imposter syndrome beaten down. So what we want to get past is a world in which we just invite people to the table and then treat them as different. We want to get to a place where we invite them to the table and they belong, right? We talk about diversity in past years. We're going to talk about it as diversity 1.0. Diversity 1.0 is diversity for the sake of diversity, right? Let's have a diverse group of people because we should, I guess. There's no real merit to it other than diversity for the sake of diversity. Diversity 2.0, well, we can make a better educational environment because if we have diverse people in the room, perhaps the educational environment will become strengthened. But now we're in diversity 3.0. We're at a place where high-performing institutions and organizations are strengthened by the fact that they have a diverse group of people participating either in a learning environment or a clinical practice and serving patients. Right? It's a different approach to diversity that we're going to talk about this morning. We've seen from many studies at Stanford Graduate School of Business that diverse teams make better decisions. These studies have been done over and over again at Google and Apple. If you take a diverse team, they'll always make a better product. So it's an infrastructure issue. It's a systems building issue. And we have to get past just a kid who doesn't feel like he belongs and get to a place where we have a high-performing institution because we're deliberate about our diversity and our decisions. So how well are we doing? We're not doing very well. Let me show you a couple of slides briefly just to talk about where our U.S. population is and how we certainly don't mirror the patient population that we take care of in the United States. So this is an interesting slide. It shows from 1965 to 2065 the projection of diversity by race in our in our country, and we've talked for many years about how we will become a minority majority population soon. The white population will go under 50% somewhere in the next probably 15 to 20 years. Interestingly, that's from a huge growth in our Hispanic population and in our Asian population in the United States, and not necessarily a growth in the Black American population. This is another similar statistic drawn in a different way by NBC News, again showing from 1960 to 2060 how the demographics of our population are changing. Emergency medicine is a white male specialty, and it has been since we became a specialty. We've stayed very consistent with about 70%, give or take, of our applicant pool being male, and similarly about 70% of our applicant pool being white year over year. We've had a couple of blips where it's been 60-40 male-female, but our ratio of white to non-white applicants has been very, very stable, despite, I believe, a lot of outreach to SNMA and other organizations to try to encourage medical students to participate. It just is not necessarily the most diverse specialty. And we see all of the Americans, right? The statistic, as you know, is every American will come to an emergency department once, on average in their life, once every 3 years. Most of those visits come near the end of life, but once every 3 years. Do we look like the patients that we take care of? We absolutely don't. We're seeing that our metro areas are becoming extremely diverse. And if you look at the large metro areas in the country by languages spoken, you'll see that those numbers of languages are really quite high. You know, it's interesting, you think of Stanford and Silicon Valley, and is that a diverse population that we take care of? We're one of the most diverse counties in the United States. We're the most diverse county in California, Santa Clara County. Not necessarily because we think of black-white, but because of all of the other racial and ethnic individuals who live in our county. Certainly the Stanford faculty doesn't look like that, those patients, at all. If we look at the U.S. physicians in the United States by race and ethnicity and sex, this is a little bit of a complicated slide, so let me just explain. So you have on the top bar, white men, white women. In the next two colored bars, you see Asian men and Asian women. And everybody else is at the bottom. And everybody else is a very, very static number. For all of the lip service, perhaps, that we pay to diversity in healthcare, and diversity in the health professions, all we've really done is narrow the gap between white men and white women. We have a lot of work to do. So with those few thoughts, I'm going to hand this over to Dr. Alvarez. This is a beautiful shot of Stanford right near the church that I got married in. If you ever come to Stanford, you must walk through the colonnades. They're great. Welcome to this workshop. Thanks for having me.
Thank you, Dr. Gisondi. Can you guys hear me okay? So, I really like the introduction about this concept of belonging and the concept of diversity and inclusion, but I want to take it home a little bit more for each of you. Because sometimes I worry that people may not think that, hey, why are we talking about diversity? Like somebody who I actually respect a lot texted me the other day because of the events that we had. We had the Diversity and Inclusion Forum at Stanford. Texted me and said, hey, I'm noticing you're doing a lot of diversity stuff. You don't really qualify as diversity. And I was like, ooh, that's very interesting. But it came from a good heart. I think they were just trying to find out, like, what was my reason for being involved in this? And I said, well, I'm not a woman, but I believe in the Me Too movement. I'm not black, but I believe in the Black Lives Matter. And I think each of us can get to the core of being allies, and each of us have had experiences where we've been marginalized in some form. And so medicine can be very isolating. When has it been in your life that you've noticed that you felt isolated in medicine, or you felt alone? This is a crowdsourced thing, so again, it's a safe space. We can have you volunteer some topics. Residency is isolating. How so? So sometimes coming into a group and they've already established some sort of community, and then you're coming in later, you don't feel like you don't belong immediately. And you have to take a lot of work to fit in. Did I get that right? Anybody else? I know many of us, if not all of us, have had this sense of isolation. Right? We've had the vicarious trauma when we take care of tough cases. And we go home and we don't really know who to talk to. Because if we talk to our family, they may not understand us. And if we talk to our friends, our colleagues, they might think that maybe I'm weak, maybe I'm not as good of an emergency medicine physician. Or the medical errors, because each of us will make medical errors. And that can be very isolating. I get terrified whenever I get a letter from my QI person that says, hey, secure. Do you guys know how that feels? Yes. Right? And you're like, do I open this? Is this like a good thing? It's so isolating because all of a sudden you are singled out as that person that made a mistake. The patient complaints is the same thing. I think it's even worse sometimes because you get like the patient complains like, I know I did a great job, but then somebody else from another lens is looking at it and saying, maybe you didn't do quite as good with your care. And for me, I take that home as, did I really doctor well enough? Do I feel like everybody else can relate to me, or is it just me? And then so if we're talking about diversity and inclusion now, add the concept of implicit bias and microaggressions that each of our speakers here will be talking about. And then you realize how medicine can be really, really isolating. And so when Dr. Gisondi talked about how all of the work that we've been doing to increase diversity, there's a certain group of people that's just not making it as well yet. We have to think from an infrastructure perspective, why is it that's the case? And perhaps we'll realize today that sometimes we're at fault, and sometimes we're also the victims of this. But I want to empower you that throughout the day today, as we learned about all these concepts, you're going to learn some skills. You're going to be a lot more attuned to things that matter to many people. The imposter syndrome, that feeling of not being good enough, right? At our shop, Paul Auerbach, and if you don't know him, he started the field of wilderness emergency medicine. And there was a talk on the imposter syndrome a couple of years ago. And he was in our small group. And he said, you know what, I feel like I'm an imposter when I work in the emergency because I don't work as much anymore compared to all you guys. Like, we're working in the emergency department. Like, you do a lot of these like procedures. And we're like, Paul Auerbach just said he has the imposter syndrome. And if you ask each and every one of you here, and if you're honest with yourselves, each of us have felt what an imposter syndrome is, right? And the idea is we need to normalize that. And then we'll cover that in our talks today as well. I want to just delineate the concept of solitude versus loneliness. Solitude is a choice. I actually want that sometimes because I need to take time for myself to think, to rejuvenate and kind of figure out what my purpose is, to find meaning, right? That's solitude, vacation. Sometimes people take like a few minutes to just like meditate and like ground themselves. Sometimes you need like a week or a little longer than that. And that's okay. But loneliness is when you have this sense of missing the connection. And connection is something that each of us actually truly needs to function. And once you lose that sense of connection, that's when you become isolated. That's when you become lonely. In all of this, we talked about the imposter syndrome, the microaggressions, the patient complaints, right? I'm lumping them all up because you know what? It boils down to the concept of shame. You've heard about Brene Brown talking about shame and shame resilience. Each of us here can actually empathize to the concept of shame because we've all felt shame. And the next talk is going to be on the imposter syndrome because I think shame is highlighted the most in that belief that we're not good enough. we're not cut out to do what we're supposed to be doing. And I'm going to open this to Dr. Hernandez and Dr. Rivera for a talk.